Hello, my name is Ken Cutbush. I'm an orthopaedic surgeon working in Brisbane. I specialise in shoulder surgery. Shoulder dislocation is a very common injury that people experience, usually playing sport, but also with accidents and so on. They typically affect people in the ages of 20 to 30, but can affect people in older age groups. Men are more commonly affected than women. The treatment for a first-time dislocation has changed over the last 10 years. 10, 15 years ago, the conservative way of treating shoulder dislocations was most commonly accepted, and patients were treated in a sling for usually 3 to 4 weeks, and then mobilised with a physiotherapist. That treatment changed because of a study coming out of the United States Army. It was called the West Point study. This study took a bunch of men and women in the Army, in the United States Army, and looked at those that had a first-time dislocation and followed them to look at the natural history of what happened to them. What they found was that there was a very high redislocation rate. That redislocation rate depended on two things primarily. One was the age at the time of dislocation, and two is the activity level of the person who dislocated their shoulder. Those two things were the best predictors of whether the person was likely to redislocate again after that first dislocation. What the study found was that the younger you were, the more likely you were to redislocate, and the more active you were, the more likely you were to redislocate. So that patients under 20 at the time of their first dislocation had a 90% chance of redislocating, and that redislocation rate dropped off over 30 years of age and again over 40 years of age. But still remains significant. The more active you were, the more likely you were to redislocate. This finding has been repeated in other studies, although in some of the other studies with less active people, the rate of redislocation has not been as high as the initial findings from that West Point study. So this has changed the way we tend to manage patients who have dislocated their shoulder for the first time. Now, instead of routinely putting patients into a sling for 3 weeks, there's generally a discussion about whether there are other options, and that other option is a surgical procedure to repair the shoulder. It's been shown that if you operate to fix these shoulders after first-time dislocation rate in someone that's under 20 years of age, instead of having a 90% chance of redislocating, their redislocation rate drops to about 5%. So for someone that is very active and very young, who can expect to redislocate their shoulder if they don't undertake treatment, they may elect to have surgery rather than to go down that high-risk pathway of redislocation. And this makes sense if you think about it. Patients that have a dislocation, if they're going to go in a sling for 3 weeks, why not instead operate on them at that stage? They're going to be in a sling for 6 weeks following that operation, and then we'll be able to mobilise them, and they'll be on the path to recovery and have lost very little time compared to if they were treated non-operatively in terms of their recovery and their return to sport. Generally, an MRI scan is performed, often a CT scan as well as plain X-rays. In the MRI scan in most patients, about over 94 to 95% of patients, there will be a tear of the anterior labrum, a bank cart tear. And at least 20% of those patients, they will have chipped off some bone off the front of the glenoid. It's the socket of the shoulder joint. In the back of the humeral head, there will usually be an impaction fracture, and that's a Hill-Sachs lesion. That's from the ball popping out the front of the shoulder and then hitting back against the edge of the socket and impacting on that edge of the socket. What we do at surgery for those patients is to place anchors into the socket, into the edge of the socket, into the edge of the glenoid, and use those anchors as anchor points to tie the labrum that has been torn off back on to where it came off from. That's done as a keyhole operation. It's extremely successful and is not risky at all. It's a safe operation and reliable. Complication rates of an arthroscopic stabilization in that situation to repair the labrum is very low. Infection rates are in the order of 1 in 600. Nerve injury is something like 1 in 1,000, maybe 1 in 3,000. And there's a very small chance of postoperative stiffness. Frozen shoulder can occur in the older patient, normally occurs in patients between the ages of 40 and 60, but can affect patients to a lesser degree, even if they're younger. If people get frozen shoulder, they'll have a sore, stiff shoulder for a period of time, often 6 to 12 months in this setting, and then it resolves completely or very nearly completely. So that is how the treatment for a first-time dislocation has changed in the last 10 years. There has been this shift towards discussing and offering surgery to patients if they're in that younger group that's highly active. For those patients, it's often a better choice than just leaving it in a sling, given that if they're very active and very young, the chance of dislocation may be in the order of 90%. Thank you.